even for us more seasoned ones, we find that if we apply science to our own methodologies, we'll get far more bear far more fruit than what we normally would do. So thank you very much. And without any further ado, I request Professor Rakesh to proceed with the session. Thank you very much to Dr. Suraj for organizing the session for all of us. And we really look forward for the time that ahead of us this afternoon. Over to you, Professor Rakesh.
Thanks, Professor John, and everyone who have taken the time out to be here with us. And without further ado, I'll just proceed to the hands-on approach, and then hopefully we'll be able to learn from the Socratic questioning, which may ensue if we have shown you something stimulating enough. So I'll straight away go to our first patient, who will be, an illustration to us in diagnostic and therapeutic reasoning to begin with, and that we think is one way of reasoning which we are trying to highlight as the system 2 approach, according to what psychologists call as the dual processing theory. So in system 2, we do the reasoning, we do the thinking, we do the analysis, whereas in system 1 there is much less of that, and it's more of pattern recognition. So when we see patterns, we are very fast at that point of time. So we just match patterns and we say, okay, this is the thing. And then we make a decision on the basis of that. So today I'm trying to show you all that, both system 2 as well as system 1. I think we'll start with the system 2 and move to a few system 1 decision making, and then finally another system 2, where we'll probably try to wrap up everything and hopefully get your questions either in between or even at the end. And I'm looking forward to it. So let's start. So yeah, so we have our residents here, we have our students here, and Dr. Pawan is holding the camera, and he has been trained not to pick up any identifiers of any patients to preserve their confidentiality and privacy. Most of these patients we have taken consent, because we have a system of taking consent even before we admit them, and we'll talk about that later. So let's go to this young man who is sitting in front of us, and I've told him that we are live with a few doctors from across the Arabian Sea, so he's also looking forward to it, and he's hoping to get some pointers from you all. And he has been ill since the last 3 months. So this is Dr. Supriya, who has made those illness scripts that we have already shared. Dr. Rajkumar has shared those illness scripts. He is also here. He's a psychologist, and because we are interested in this field of medical cognition, that is diagnostic and therapeutic reasoning, a psychologist, because it's ultimately about psychology, the psychology of the mind, and how we think, how doctors think, how patients think, and how to make our students think better. So Dr. Supriya has already shared the illness script of this patient, which he has gathered, and we have shared it across in that group. I'm not sure if all of you are there, but I'll give you a small sequence of events which he had, because ultimately we are just giving a demo of how to move from symptoms to diagnosis. The symptoms with which he started was, he's an auto driver by profession. I'm not sure if there are autos there, but in India the auto is kind of a vehicle which is a three-wheeler, very often used, and if you're sitting on it, it doesn't have much of a spring action, so it's a very bumpy ride. And he has been noticing in the last 3 months, 3 to, I mean, he told me it's 8 months, but anyway, so he's been noticing. Yeah, so what he told me was, I mean, yesterday I was also taking his history in his language. Now, language is very different because he has come from 2000 kilometers. The next patient I'll show you is from 20 kilometers. So the language in India varies from every 500 to 1000 kilometers. So he has a completely different language. So I asked him in his language, and he said that he was feeling this when he is driving the auto and he is driving for a long time, after 2-3 hours, he feels as if he's got an extreme heaviness of the leg. He is not able to move his legs. They feel very heavy, as if somebody has put some weight around those legs, and he also feels kind of numb in those areas, and he has this kind of tingling sensation. So this is the exact thing, description, the script which he shared with us, and we did not know what to make of it. And to tell you the truth, when he came to us for the first time, this 2-3 days back, we did a system one. We just quickly saw him and we asked him what is the problem. Maybe we were in a hurry or something, and we then proceeded to do an examination. So perhaps we will also proceed with the examination and tell you what we found. But even before that, the person who brought him here, our patient advocate, he said that they'd already got an MRI done and that was normal. So that again biased us to think that maybe we were dealing with something else. And when I saw his gait, I thought he was, lifting up his legs as if there's a steppage kind of a gait. We also call it an equine gait, like a gait, as if gait of a horse which is just moving slowly. So that's what I thought. But now I don't know what you will make of it. So so be careful with the identifier. Yeah. So Pawan is just showing you the legs so that you can appreciate how he is walking. Now, although on that day I felt he was lifting his legs like a horse, later on when I examined him, after examining him yesterday, I don't know, I don't feel that is the same gait. I will show you now. Can somebody go along with him so that he doesn't go? So our resident of Ravi is walking with him, and you can see his legs. He is walking carefully because what you might notice is that he is walking very carefully, and that may indicate nothing else. That may indicate that he doesn't have a lot of balance. And do you notice that he is dragging his feet a bit? Well, maybe it's not very noticeable. Only thing I can make out is that he is walking carefully. Now, if somebody is walking carefully and he doesn't have balance, can I make him walk on a tight rope? So I'll ask him to walk on a tandem. That is, I'll ask him to walk on a straight line here. So Pawan, please do, and Ravi, you be ready to catch him if you want. Yeah. So, he's straight line down. So yeah, you can show them the hands also how. Yeah, he's able to manage it. And he's got a little bit of swaying, that's all. A little bit of swaying and a little bit of thing. Which is slightly, slightly less than normal, I would think now. Of course, I have become biased by my examinations, but when I saw him the first time, to tell you the truth, I thought he had an equine gait. I don't any longer think so. That's a Shivu. Now, Dr. Chandana, would you like to show us the examination findings of the spinal cord? So, essentially, we want to see where is the localization. So, now we come to the diagnostic reasoning part, which is, what we teach our students right from the final MBBS days. That is how to localize any problem, any illness has to have an anatomical localization. So, now from his history and a psychosocial perspective, we are moving into the body proper, where we are trying to localize the pathology. So does he have a pathology which is giving rise to his symptoms? So generally for most of us in the field of biology, it would end here. I mean, we would be satisfied with the data points that we collect about the pathology, and we would basically try to tackle that pathology. But as we go deeper into medical science and cognitive science and this field of medical cognition, we realize that there are many more data points to be collected which can help us to do better for the patient. So we will show you how to collect the body data points. So Dr. Chandana is going to illustrate. She will straight away jump to by showing us the motor system examination. We are telling you that the higher mental function is normal in his neurological examination. The cranial nerves are normal, and his neck doesn't seem to have a problem. His spine, from whatever we have examined, doesn't seem to have a problem. And so straight away to the motor system. So we can start with the power and then the reflexes. Do it quickly so that we can show them more patience. Yeah. হ্যাঁ ওটা আপনার দিকে টানুন হ্যাঁ হাতটা আপনার দিকে টানুন yeah so he is trying to pull and the other one other hand upper limb so Chandana what do you think about his power in the upper limbs Achha, do it in the lower limbs show the lower limbs yeah and you can just put your hand on the knee joint yeah and let him flex it it is clear that you put it and try to see এবার তুলুন পাটা তুলুন সিধে না উঠে ভাঁজ করে ওঠাতে পারেন হ্যাঁ ভাঁজ করে ওঠান ভাঁজ করে yeah so for a young man I think this is less okay then again yeah this is slightly lesser and going by the symptoms he had more problems in his left lower leg so I would say this is 4 minus or 4 plus power okay the 5 is great 5 is normal and 4 minus 4 plus is less than that 3 would be that he is able to move against gravity but it is much less than normal so this is just less than normal and not much less than normal which is why you see he's almost normal I mean if you had seen him in some other place you wouldn't have been able to make out that he may be having a neurological problem or he may even have these neurological symptoms but he's come all the way 2000 kilometers for a solution so he must be having a problem although his MRI is normal so now we'll come to why his MRI was normal but before that let Chandana demonstrate the reflexes yeah so we start with the upper limb reflexes so, yeah focus on the biceps yeah so as you can see there is no contraction of the biceps go ahead to the next now here you can see there is no contraction of the triceps either or maybe a very vague one okay go with the brachioradialis here so there is no contraction here also Chandra can you do that so the biceps are absent, the triceps again. Yeah, triceps you just need to pull it here like this. And okay. So here it is. So even this triceps is not there. And let it be here. And this is the brachioradialis. Even this is not working. So none of the reflexes here are working. So all these signals that we are sending to the spinal cord, they are getting blocked either in the afferent pathway while going to the spinal cord or while coming back from the spinal cord. So either way they are blocked. So we don't know where the block is. Is it at this nerve level or is it at the spinal cord level? Be careful about the identifier. So we don't know where the block is. Now let us go down to the lower limbs. Okay, so yeah. So here you see the knee. And let's see the knee. So as you can see, the knee is jumping as opposed to the biceps and triceps and brachioradialis, which are not at all reflex. I mean, they were absent. But here it's jumping. The ankle is jumping. One could even call this normal, but it's probably exaggerated. Now, here. So you can see a little bit of subjectivity, but we are convinced because of the overall picture that these are exaggerated reflexes. Now here you see this is also jumping. Now let us look at his plantars. So this is the toe. Now in plantar extensor this will become like this. In a plantar flexor this will become like this. Normally it should become like this. So let's see what happens here. So as you can see it is becoming extensor. And in this side also it's extensor. So bilateral plantar extensor, hyperreflexia, absence of reflex there, what would we think? Now this is the crux of the diagnostic reasoning where one would require a knowledge of anatomy, only knowledge of anatomy, nothing else, just anatomy. One needs to know the spinal cord, the anatomy of the spinal cord as well as the brain, the cortex and the peripheral nerves. So essentially, there are pyramidal tracts coming down, and there are inhibitory interneurons. So what has happened in what we can make out from this clinical picture is that the current is absent in the upper limbs totally. So we can hide, but it is all present in the lower limbs. The current is present. So we can say that either the nerve, the wire here has gone, or there is a problem in the spinal cord here, especially that segment of the spinal cord which supplies this, the biceps, the brachioradialis, and the triceps, which is C5, C6, and C7. So these segments of the spinal cord are damaged, and that is the reason we don't have any current here. And because these are damaged, that is the reason we have the lower limb showing hyperreflexia as well as plantar extensor, which is a very, very classical feature of what we teach our first year students in physiology, upper motor neuron lesion. So the upper motor neuron starts from the cortex as pyramidal cells of beds, and then it goes down to the um, spinal cord and anterior horn cells, and after that it comes out as lower motor neuron. So here we think it is an upper motor neuron problem, which is affecting the lower motor neurons also, which are coming out of the spinal cord, and that is the reason you are seeing a partially lower motor neuron type of lesion in the upper limb, but upper motor neuron type of lesion in the lower limb. So this is what we are thinking. So the entire thing, from when I saw him 3-4 days back when he came the first time, I thought he had a equine gait, a foot drop, and then I changed. Once I immediately did this quick cursory examination, I changed my diagnosis to a spinal cord problem, and that too at the level of the cervical region. Now that thing about the MRI, why his MRI was normal, we found out because they had done it wrongly. They had not done the MRI in the cervical region. They had done it in the thoracic or probably even lower down, because he was complaining only of a left lower limb weakness along with bilateral limb heaviness. So they thought it must be a lumbar problem, and they did the MRI there. So here you see how a little bit of clinical objective finding and diagnostic reasoning, which is very basic. I tell you, whatever I showed you was basically MBBS anatomy physiology knowledge. This kind of basic thing allowed us to get a different viewpoint of where we should do the testing. So here we changed the entire diagnostic reasoning, and we switched from the lumbar region to the cervical region. And we can show you the MRI of the cervical region. I think they're showing it to you from another desktop which is there in the ICU. And is it shared in your screen? You can see how it looks like. Let me also have a look. Yeah, that's okay. I'll just take a look. Yeah. Okay, so you can see it here. In this C5, C6 region, I don't know whether you can see my finger. But so you can see a compression by an intervertebral disc. I think the previous one was better. The previous picture. The previous picture. The first one. Not these. This one. So you can see an intervertebral disc, which is a black, a relatively darker. Yeah, can you make it bigger? A relatively darker thing. Yeah, and do we have any cursor to show them? Because I am pointing my fingers, but I don't know whether anybody's seeing that. Huh? Yeah, Charan, can you show them this black area? Yeah, exactly. Which is compressing the spinal cord. And this is at the level of, exactly at the level of C5, C6, C7, which we could clinically find. So you see, there is a very strong correlation between our clinical diagnostic reasoning and the visual MRI findings. Very, very strong. So this is pathology. This is the body and the biology which is generally mostly thought to be part of diagnostic reasoning. And this is a very simple thing. There's nothing much to it. And already now we are moving into the therapeutic reasoning. So what should we do? Initially, the patient was scared that should we operate, and he is currently moving around. He's almost normal, as you can see. So should we operate on a normal person relatively? And then what if he becomes more paralyzed? Nobody will be able to forgive. We won't be able to forgive ourselves. The patient won't be able to forgive himself for that decision. So here is a very, very crucial decision. Should we go ahead and operate or not? The surgeon feels yes, we should. Because he has definitely got a reason that he says that if he doesn't tackle it now, it may become more difficult. And of course, we know that as time goes, the compression may cause further problems in the neurons, in the functionality of the neurons. So, I mean, he's right, of course. And so, what do we do? I mean, how do we make a decision? Do we leave it to the patient? Like, there's currently a shared decision making movement, and we need to be able to share all our uncertainties with the patient and allow him to take an informed decision, which means the onus shifts to the patient. But although we'll still be supporting him with whatever information and guidance that we are capable of, but then in the developed world, it's very difficult for a patient to be able to bring out that much of capacity to handle this kind of uncertainty. So most of the times, I don't know, maybe even in the developed world, patients would rely on the decision the doctor takes for them. So if the doctor says, okay, let's do it, they will also more or less try to arrange all the resources. It's not going to be very, it's not very expensive here in our institute, but it's not completely free either. So there are a lot of resource constraints which need to be tackled, and the most important thing is the outcome. So what could be the outcome? I have shared a PDF of clinical tips and diagnostic reasoning with Dr. Siraj, and maybe I'll share it again in the WhatsApp group if all of you are there, if you've not gone through that already. And they talk about Bayesian analysis here, which means that you think of the priors. What is the prior knowledge in this area as to what happens to people when we operate in this particular situation? Let us say a young man who is relatively well preserved functionally, and you operate on 100 such people. What are the outcomes? So if you already know of that, isn't it simple to say that yes, if 90 out of 100 had a good outcome and the rest 10 did not have that much of a bad outcome, I mean, they didn't get completely paralyzed, then one can have reasonable confidence to say that yes, why not go ahead with it. But on the other hand, if some people say or find that 50 people had worse motor deficit than what was earlier, then of course we wouldn't like to do that. So the only hitch, of course, there is a lot of good data available, but there is a lot of data which is not available. Like every day, there's tons of data that is getting wasted. So many such scenarios who are not getting recorded and not getting shared. So what we need to do is build up such a database, and that is, I think, one of the reasons that we are sharing all this with you here, is that we want each and every such illness script and each and every such clinical encounters to be documented, so that persons who are also having the same problem can access those and make a much more better informed decision, rather than just go by what is currently available as numbers and mean values. So anyway, so I think we have done a little bit of system 2 thinking here. Now we'll quickly move on to a few system 1 cases where we'll also talk about the anatomical approach and biologic diagnosis. In the meantime, would any one of you have any questions about this patient or any comments? Maybe some of our team members might want to make a comment, particularly from the cognitive side. So no one. Shall we move to the next patient? Dr. Rajkumar, would you like to talk something about the psychosocial aspects of this patient? Because you see, again, we have to deal with a lot of data points. It's not what we showed you was very simple biologic understanding of the body. But there is so many more data points which are psychosocial, which would be very important to gauge the the level of decision that needs to be made. So we haven't addressed that, and probably we are taking a shortcut there. So there's a lot to think about here, and a lot to spend time with the patient around this. So if Dr. Rajkumar is not giving us any, Supriya, you have any inputs on this? Yeah. Would you like to?
His father that affected him in his life aspects.
Yeah.
At early age, at 12 years of age, he lost his father.
Uh-huh.
That turned his life into ups and downs.
Yeah.
Like he discontinued his study at 8th class,
Right.
and continued as a daily wage laborer in construction.
Right. So loss of father in early childhood, child labor because of that. Good points.
And
yeah.
he also lost his mother at the age of 15 years.
Again,
that made him alone.
Again, losing both parents at a time when most people would consider it as a child. Yeah, losing both parents at 15 years, child labor. So these are very, very important, aspects to his entire condition. Yeah. What else?
And if they have small disputes in the families regarding land and all.
Yeah.
About financial issues.
Yeah.
And that's it. And his first child was the expired, sir.
Yeah.
At the age of 1 year. They stayed up till 3 months in the hospital, but they couldn't save him. After spending 80,000 rupees also.
Yeah.
That may be acted as trauma on his mental health.
Yeah. So there's a lot of pain points in this patient, which is suggesting that there is a lot of possibility of psychological issues. But and what we are seeing biologically is a gross MRI finding with some very good biologic data showing us that there is a loss of reflexes, there is a plantar extensor. So we cannot throw away any of these. So is it, we cannot even correlate how these psychosocial issues are correlating with this prolapsed intervertebral disc. In fact, why did he have the prolapsed intervertebral disc? And at what point of time did he have this? He has had symptoms in the last 3 to 6 months. But when did he actually develop it and why did he develop it? What were the reasons for developing a prolapsed intervertebral disc? That too at the cervical region. He had a history of trauma maybe 10 years back, isn't it? And but 10 years back, and why is he having a prolapsed disc now? We know in the classical history of prolapsed disc, it is the patient is lifting a heavy weight and suddenly the patient has a sensation of giving away and sensation of pain followed by neurological deficit. He never had that. At least he never complained of that kind of sudden onset. So why he and how he developed this prolapsed intervertebral disc is also a mystery for now. So although we've got an anatomic diagnosis, we still don't have the etiologic diagnosis. We just know that there is a prolapsed intervertebral disc. But why did it prolapse is still not clear, isn't it? So now let's go to a quick few system 1 reasonings, and we'll again come back to another system 2. So here is one of our patients who has come to us, and this is Dr. Haripriya, who saw the patient at 2 a.m. when he came, isn't it? Yeah. And he was complaining of a lot of sweating, isn't it? A lot of sweating followed by giddiness and
Difficulty swallowing.
yeah.
Difficulty swallowing to solid fluids.
Yeah. So sweating, giddiness, difficulty in swallowing, solid foods, hiccups, and anything else, and giddiness, isn't it?
He was unable to stand.
And he was unable to stand because he was losing balance. So in a system 1 approach, if we see a sudden onset of these cranial nerve symptoms along with motor weakness, so cranial nerve symptoms here are the giddiness is most probably because of the brainstem vestibulocochlear nuclei. The difficulty in swallowing is because of the 9th, 10th, 11th nerve, which are coming out of the middle oblongata. And if there is a middle oblongata involvement anatomically, we call it the medullary syndrome. It can be a lateral medullary syndrome or a medial medullary syndrome. And looks like, and that is because of a vasculature which has been probably blocked. Now, that is our first impression. Anything sudden neurological finding could be a vascular phenomena, and he has the age, he has these vascular risk factors in the form that he is a diabetic for 4 years. He is how old? 49. 45-year-old, and he regularly consumes alcohol, a lot of alcohol. So we know that vasculature, the endothelium can be damaged by alcohol as well as visceral fat, and he has smoking also. So given these risk factors, we think that it's most likely a vascular phenomena. The other possibility, differential, is that it could be a demyelinating illness. So the neurons which are around in this area could also be inflamed, essentially attacked by our immune system, and that inflammation can set off a demyelination, which can transiently block all their functioning. So either of these two are possibilities. We'll put our money on vascular, and let us see the way he is walking. Can you ask him to walk a little bit? So he's much better than what he was when he came to us 2-3 days back. Can you, Kotiga Narvandi? So you can see here it is much more clearer. That man was also probably having a little bit of ataxia, the previous patient. Here this man's ataxia is phenomenal in comparison to his, because he's having much severe ataxia. Like even if you see him anywhere, you'll be able to make out that he's got a neurological problem. So yeah, now he can turn. See how he turns. So see how he's turning. So he's got a lot of problems, and it's all because of the involvement. Now the previous patient's involvement of ataxia was because of the spinal cord area, which are called as posterior columns. And this patient's ataxia is possibly because of the brainstem, where the cerebellar tracts are moving. So because of involvement of the cerebellar tracts is what we are seeing this severe ataxia. And in that man, it was more of a sensory ataxia, where he was not able to appreciate the ground below his feet. He was probably feeling as if he is walking on cotton wool. And that is the reason he was having a milder ataxia. And we confirmed that by making him stand with his legs closed and asking him to close his eyes. And he was faltering and he was nearly falling down. So that is called Romberg's sign. So in that previous person with a spinal cord problem, involvement of posterior columns, lateral spinothalamic tract and pyramidal tract, he had a Romberg sign positivity and he had a mild ataxia. This man with a brainstem lesion, possibly because of a posterior circulation blockage, sudden onset, has got a severe ataxia. And of course, the therapeutic decisions here are relatively easier. If he had come on time, we may have been able to thrombolize him or tackle the vessels. But most of the times, we see these patients 1 or 2 days later. And there we just resort to secondary prophylaxis by giving antiplatelets, statins, and essentially we train them to get back on their feet and giving all the mental and physical support that is necessary. So that part is simple kind of therapy. So let's move to the next patient. So we will take a detour here because we have shown the. Yeah, do we have his X-rays here? Yeah. So yeah, you can just focus here. So this patient is also in the next bed as the first one, and both of them live nearby. They have all come from 2,000 kilometers. The previous patient which I showed was from 20 kilometers here. Now this patient again is from 2,000 kilometers away. And can you see the scars on his abdomen? Any light? Can you see on it? What is the time? 3:10. So we have just 20 minutes more. So yeah. কোথায় যেন ঢোকানো হয়েছিল ওটা? ফুটোটা? এখানে? হ্যাঁ? হ্যাঁ? এটা? এইখানে. So yeah, you can see a scar here, very small scar. This is a surgery which he underwent, and it's a laparoscopic scar. We've got a professor of surgery there, and following the surgery, he was not completely all right. Operation করার পর আপনি কিছুদিন ভালো ছিলেন? কিছুদিন কতদিন ভালো ছিলেন? এক বছর ভালো ছিলেন? Fantastic. So he was quite all right for 1 year. Actually, we are doing a short case. I didn't take the history here, and I don't think anybody else did in detail like Supriya's history. We don't have a history here. So yeah, he had this operation 1 year back, and he was okay for 1 year. And then, এক বছর বাদে আপনার কি অসুবিধা হলো? And then he started having a pain in this lumbar region, lumbar and right hypochondrial region. So this is the history. Pain আর কিছু না. And did he have any fever? কোনো জ্বর টর মাঝে মাঝে আসতো? So when he had pain, he also used to have fever, 2 to 3 days of fever along with the pain, and then it would subside. Then it would subside, 2 to 3 days of fever. And what we found was remarkable. Can we have a look at that? So we examined the abdomen. We didn't find anything very critical in the clinical examination, but we jumped to. He had already actually gotten some CT scans done, and we got one CT done here. And let us. Yeah, you don't have that. You have. You have. Yeah. So there is. Yeah, we'll be sharing you the screen with that picture. Yeah, so yeah, Sai Charan is showing us the image. Yeah. So can all of you? Oh, yeah, we shouldn't have made all these. There was no point in making all these colorful diagrams on the CT. But yeah, so yeah, what happened? Okay, there's a network issue. Shall we try to show them the CT on the bedside? Let me have a look. We'll try to steer clear of the yeah. Okay. So yeah. So try to not catch the identifiers. So this is the liver, and it's a very peripheral, situated abscess that we are looking at. And here it is. In fact, one can put a needle and drain it, but the thing is, there is a gallstone also here, possibly a radiolucent, which is rare. We can see a radiolucent stone here inside the liver capsule and the abscess. So it's here as well. As you can see it here. Yeah, there are no identifiers also here. Oh, there's an identifier here. So this is the situation. So so right now, I think maybe Professor John can give his opinion as to what the surgeon should do in such a situation.
Yeah, I suppose you can see there is some sort of a collection there, and the CT seems to show it like that. So perhaps best is to aspirate it if at all possible.
Yeah, and then when we looked into the other images, I think Sai Charan is only showing one, which we showed you right now. There seems to be a stone there, and probably it's at the gallbladder fossa region. So we are wondering whether just a blind aspiration will help, or essentially we should open up and again explore that area and probably do some repair if at all anything we expect to find. So right now we are in this uncertainty as to what would be the best course. And yeah, the choices are between re-exploration versus, as you said rightly, even we thought so, that it would be very easy to just aspirate it. So these are the choices we have. And again, ultimately the choice and the decision has to be made by the surgeon. So when you are the surgeon, that is clinical judgment. So you make a judgment, you take a call, and then either you move ahead in one direction of aspiration or you move ahead on the other direction of exploration.
That's right.
So either way, it's the patient's benefit that is paramount. And again, we told him that we will be showing him to some of the esteemed guests like you, and I'm sure he is very happy to have a second opinion from you. And we'll keep you posted on what ultimately happens. And if we do explore, we'll also share those images with you all, in fact. Yeah.
Thank you.
So let us move to another quick system too. Okay. Here we have a patient. Now we already showed you one patient, in fact 2 patients of a neurological problem, one with a spinal cord, another with a brain stem. Now this patient is also having a neurological problem. As you can see, he's got the most amount of motor power weakness. As you can see, when I take his hand up, it is falling like a log of wood. The hand is falling like a log of wood. which means probably he's got a grade 0 power, maybe grade 1. So he is the most powerless in terms of muscle power in our ward. And this is not just in his hands, it is also in his right lower limb. Now this is the fastest and the simplest case in the ward, which most of us will be able to look and tell what is happening, because his entire half of the body is paralyzed and it has happened suddenly. Again, a vascular phenomenon is the first thing which comes to mind, and this is what is commonly known as brain attack or stroke. Previously it was stroke, nowadays the common term has become brain attack. And for us, the term is anatomical diagnosis. Now that we're coming to diagnostic reasoning in a system one manner very rapidly, the anatomical diagnosis would be in the internal capsule. And generally, this artery which supplies this area is the lenticulostriate branch of the middle cerebral artery. So, left lenticulostriate branch of the middle cerebral artery is what is blocked in this man. And this man actually had the same problem 1 year back. And interestingly, recently he had stopped his antiplatelets and statins, and after which, and antihypertensives also. And what was the reason? I mean, that reason is probably psychosocial, which is where Dr. Supriya can help us to find out why he stopped those. And of course, we also have to look at the evidence as to how much, was it really because of stopping or was it just coincidental? So, for our students, who would pose them with the task that why not go through the RCTs of antiplatelet therapy versus placebo, which may have been done 30-40 years back, and why not go through those RCTs of statins versus placebo and see how much of real efficacy did they really have, and then we can also think of or assume that by stopping these is what precipitated it. Otherwise, you would need much more data about his life events to see what exactly went wrong. Was it really stopping, or was there some other precipitating factors, like some other psychological event, which may have, because ultimately this was at a pathological level, a rupture of a plaque in that lenticulostriate branch of the middle cerebral artery. So, if that was a rupture of a plaque, why did it rupture? Was it because of stopping the statins, or was it because of some other event, some psychosocial event? So, that is what we need to explore. Okay, we'll move again to the other patient. So, we are coming to the end of our session. How much time do we have?
14 minutes.
10 minutes. So, now we have another patient here who has come to us for how many months? 10 days. 10 days, yeah. 10 days. Yeah, so a 70-year-old man who's complaining of cough and shortness of breath since 10 days, and he was absolutely okay 10 days back. No other issues. But Supriya has found out certain interesting background. So because it's a system 2 long case, although we have 10 minutes, maybe Supriya can shed more light on his life events. Yeah.
This 75-year-old man is a farmer by occupation. He's from Jangareddy-Gudem. He's uneducated but can read Telugu newspaper.
Right.
He got married at the age of 28 years.
So you mean to say he doesn't write, but he can read?
But he can read.
Very good.
He was married at the age of 28 years, and where his wife's age was 17 years. He worked really hard in the field since childhood, as his father got expired at the age of 5 years.
Okay.
He built their own house at the age of 30 years, and they have their own land of 5 acres area now, and he has 2 children. After 10 years of his marriage life, he gave birth to the first child, his son. His age is 40 years now. He has 2 children, and they stay at their home place with this family only, with this couple. And his daughter is 36 years old now. She has 2 daughters. She stays at Kodada, and he gave 3 acres of land to her as a dowry. His son and his family stays with this couple only, him and his wife. But he works in his land and stays in his house, but he won't care about these people. He won't give money for their expenses. They won't allow to watch TV.
This is the wife's version.
Wife's version.
Okay.
They always scold about the money they have given to his daughter as
So
a
the wife
dowry.
is not happy with him, the patient.
No. with his son.
Okay, the wife is not happy with his son.
Son's
okay,
family,
fine.
as they are not caring about them.
Right.
They are not giving money for their expenses,
Okay, right,
and
right.
they are not allowing to watch TV also.
Right.
They are not caring them, as they are living in their house, but they are not caring them.
Okay.
And they always scold about his dowry.
Okay.
As
So
he
that
was given
Yeah.
3 acres of land to his daughter,
Yeah.
they
So
are
they're not
always
happy about
bothered
it.
about
Okay,
that
right,
land,
right.
and they always scream about
So
it.
his sons are not happy, and they are also unhappy because of that. That's the bottom line. Okay, what else?
They became emotional and they cried a lot while
Okay, while
explaining
they were
about his
telling
son
you
and
the
his
history,
family.
they became emotional, and they cried.
He
And
really worked hard in his early days, but he's not happy at his old age
Yeah.
because of his son and his family.
Okay, so they're unhappy
They're
from that psychosocial perspective. Now, 10 days back, as Haripriya said, he was having this cough and shortness of breath. And when he came here, I think Dr. Haripriya looked at his chest. So, yeah, be careful. So, this is the front of his chest, and this is the back of his chest. And we will now examine the back. We have, I think, 5 minutes. కొద్దిగా నిల్చోం కదా టర్న్ చేయండి okay, very good. So now we will have to pull it up. Okay, so now let us, can you focus on my fingers? Yes, sir. Can you see there's something interesting happening? I'm not sure if the camera is able to pick up. Can you see anything in the camera? I mean, through your camera? So here what is happening is my left thumb is not moving, my right thumb is moving, and I have placed my entire hands on his chest, in the back of his chest. So it seems as if the right side is moving properly, but the left side is not. Left is also moving, but much less than the right side. So there is some pathology on the left side, and you can see some bandage here. So many people will guess what it is. Now I can show you the sounds. I'm not sure if the video captures the sounds. So we can hear that the sounds here. No, let me do the percussion properly. So here the sounds are less. It's tony dull here, whereas in the same place these are resonant. So normal lung here, abnormal findings here. So this is a classical finding of a pleural effusion. Classical finding of pleural effusion. Is Charan sharing his chest X-ray? Okay, we can sit down. Both. Kurchodi. Yeah. So Charan, are you sharing the chest X-ray here? So you can see it's a very, very simple pleural effusion that he has had, and this was all 10 days. 10 days of cough and shortness of breath. So what is the reason for this? So could it be heart failure or could it be infection? So we did the tap and we found that it has got a lot of cells, mostly lymphocytes, 2,400 lymphocytes, and the proteins were high. It was exudative. We used the light criteria to find out whether it was exudative or not. And it was satisfying all the light criteria, more than 0.7, the protein and LDH ratios. So, yeah. So, everything is fitting into an exudative pleural effusion with a lymphocytic pleurocitosis, and this very commonly refers to tuberculosis. Now, if it was just a pleural tuberculosis, we would have treated for that. But how to diagnose, how to label? I mean, we know from Koch's postulate that the organism should be there. Otherwise, there's a lot of assumptions. We are making some epidemiologic assumptions here because it is common in this part of the world, and that's why it may be. And we start him on empirical therapy. So, should we start him on empirical therapy, or should we try to see what the organism is? We tried. We sent the sample for CB-NAT, and we also sent the sputum for AFB. Nothing has yielded us microbiologically so far. So the biggest question is, should we send him home without any anti-organismal therapy, or should we start him on empirical antitubercular therapy? And we haven't yet resolved this dilemma, which is why he has also got another problem of BPH, which is being looked at by the urologist. So we are thinking that we may have to wait and see, wait for And we are like trying to look at the parenchymal involvement of the lung, because if you see that X-ray, it's covering up. It's just showing you the pleural part, and you can see a normal part of the lung, but what is beneath or underneath that pleural effusion is what we cannot see. So for that we need a CT scan. So we are waiting for that CT, and if you can see if there is really parenchymal involvement with cavitations and pathology, that will be easy for us to start immune antitubercular therapy. But if there is none, then whether this is just extrapulmonary tuberculosis or something else, we will still be in a dilemma. So what is the time now? Is it 3:30? Huh? 3:25. So we are coming to the end of the session, and I think we'll leave you with this dilemma, and we can work on that in the coming few days if you are with us and if you're in that group. And if you would like to inquire, we will be sharing all these stories that we have. And yeah, so can we have some questions now? It can be general and it can be anything.
Thank you very much, Professor Rakesh, for this. And I can see Dr. Siraj is still around. Yeah. So, friends, you have it. And
Sir, Dr. Firdaus has a question.
Yeah, go ahead. You want to read it out?
Yeah.
You need 1 minute. Dr. Firdaus?
Yeah.
No, it's not unmuted yet.
Okay.
Dr. Firdaus?
We can't hear, sir.
You lost your video. Oops. Yeah. You want to... yeah. You want to type the question, perhaps? The chat should be there. Come back. Dr. Siraj, can you see the chat?
Nothing has come in the chat. We are just asked. They have asked her to unmute, but you can still see her hand raised. But there's no video. Yeah, maybe some connection issues. She'll come back. We can see if anybody else has a question.
Yeah. Anybody else would like to ask anything? We have our friends from Rustak also here, Dr. Ajit and Dr. Kohli. Yes, Dr. Kohli. Can you unmute yourself?
Am I audible, sir?
Yeah.
Yes,
absolutely.
Yeah, I had an observation to make regarding that liver abscess case. Right. Now, actually, when the clinical things were presented, I was a little disturbed. I could not see hear everything. But as I understand, it's a liver abscess. And we were discussing about the method of treatment. Dr. John suggested it should be aspirated. I like to say that these liver abscesses, I don't know what type of abscess. Is it amoebic? It is infective. So whatever, the liver abscesses are known to be very thick abscesses. And if we when we say we will aspirate, probably we mean we'll drain and put a tube also. So if we do transabdominal aspiration, we won't be able to put a thick, wide enough tube. And they are very prone to get blocked. So I would say it would be a better option to go in, leave laparoscopy, not necessarily open, drain it and put a wide bore tube, because they are very, very notorious to get blocked. So if we only do percutaneous aspiration and we will even put a thin tube, it is all possibilities of getting blocked and we will be stuck. So I would say that we should go in this case, maybe laparoscopically, and also at the same time we can look at the stone. We can manage that also in one go probably. That is what I just want to suggest.
Yes, we agree with that. And hopefully we'll be able to show you the re-exploration images as well.
Yeah. Thank you, Dr. Kohli, for your input. Any other? Yeah, I think we've got Dr. Firdos's question. In primary care, sometimes the disease is evolving so clinical signs are difficult to elicit.
Yeah.
I think somebody's answered also from your side.
Yeah. So the clinical signs are difficult to elicit, and the question part. What was the question part of it?
I think what is being said is in ambulatory settings where you don't have so much time to reassess and assess repeatedly. Perhaps the clinical examination, the first sitting may not be as good. And therefore, how does one go about it? I think that's what is being said.
Okay, right. I got it. And it's a very important question. So, I think not only just I think there is a lot of evidence that it's not just the most important is the sequence of events of the patient's journey as it evolves. So when the patient starts from a point A and goes to a certain point when he comes to the physician, point B, let us say, a lot has already happened. And that is the time the primary care physician has to figure out as to what the diagnosis and planned therapy is. So most of the time, it is that data, the event data, which will help the physician, and we call that loosely as history. And it can be so many layers of history, like biological history, psychosocial. So that is a very, very important. 90% of the time, the diagnosis will come from there. Now, what happens is, as we already showed you, the next few clues to the diagnosis will come from the examination, clinical examination, and the final, the strengthening, the putty or whatever you call it, you just strengthen the entire foundation by confirming it with a few investigations, which will give you a better visual idea of the anatomic area involved and the pathology involved and the possible etiologies. So when we talk about investigation, it is not in isolation. Like, often what happens as physicians is through WhatsApp or whatever, people just shove a lot of reports into our face and then say, just tell me what is wrong with me. We say we can't tell you anything seeing those reports. I mean, they're just a bunch of numbers. So we have to see you in entirety. What happened to you? When were you completely all right? And what happened after that? And why did you get these reports done in the first place? So this is a very, very common issue that we have to deal with on a daily basis. So yes, investigations are very, very important for strengthening our foundation. But we have to reach that level. We have to first make the house. And the house is made by the sequence of events, which needs a very, very patient listening on part of the physician and building up the entire story, the illness script as they call it, and followed by the clinical findings. And when we say clinical findings, you can also include the investigation. So what we mean that about clinical findings and investigations, that is internal medicine. That is what we see inside the body. But there's a huge area of external medicine which is not inside the body but is influencing the body. Whatever the body is showing you is all because of the external factors which is influencing it. And that, of course, nobody calls it external medicine, only I do. And probably it's better called as community medicine, primary care. But essentially, they're all the amount of environmental, exposures that the gene or whatever, the protein product of this body is being exposed to. And that combined effect is what is in front of you.
Professor Rakesh, in your own example, you mentioned that, the first time you saw this patient, you thought the gait was equine. And then later on, when you evaluated the patient, you had a different opinion. And perhaps even as this video was going in also, you were sort of, it was sort of shaping up in a different way.
Exactly.
And now you talked about system 1 pattern type recognition and also system 2, where it's more about thinking. And trying to correlate it with Dr. Firdos's question on primary care, would it be fair to say that sort of the primary care, because she's a family physician, by the way, in family care, would it be more sort of focused on, when you teach students, particularly on pattern recognition?
Which is system 1 in a way, yeah.
Would that be a fair thing to say, or?
Well, I would think that primary care needs system 2 more than system 1. System 1 pattern recognition is the kind of expertise which you develop over time when you repeatedly do the same thing again and again. And nothing is stopping a primary care physician from doing that, but it's basically practice. The practice of medicine is what keeps on building up in installments in our brain. And as soon as we see something, we can immediately recognize the pattern. And we cannot explain it either as to why we are doing certain things. In system 1 thinking, it's like that. System 1 thinking is essentially no thinking. It is just pattern recognition and reflexively doing certain things. And it's very useful when you need to take quick decisions in emergency situations. But in a primary physician's chamber, it need not be always necessary. What is required for a primary physician is to spend a lot of time with their patients, which is of course always short, but it is very, very essential that we primary physicians spend a lot of time and take out all the kinds of biological, psychosocial events that has gone in the patient's life, and then become a part of that journey which they are experiencing and suffering from.
Thank you very much for that. Anybody else would like to ask or clarify any doubts or? Yeah. Dr. Siraj?
Nothing from my side, sir. I must thank Dr. Rakesh, and as you rightly said, we will have this association, built in firmly, so that some of our colleagues couldn't join because they had academic assignments, and Dr. Rakesh insisted, let's start today. So we'll be looking forward to further iterations and how we can take this forward. But I must thank you for sparing your time, your resources, and your entire team for helping us out with this very important venture that we have planned in this college. I would request Dr. John to wind up the session. Over to you.
Thank you very much. In fact, it's been a pleasure having you all today. And first of all, I must thank Dr. Siraj and from the Department of Medical Education here for organizing and arranging this session. It's something that many of our external examiners who come to us for exams point out that students have theory knowledge. They seem to be able to apply, do the clinical examination, but it's this critical thinking that needs to be refined or worked on. And that's a background by which this session was organized. And I must thank you, Professor Rakesh Biswas, and your entire team, your well-trained videographer and your other residents there who helped us.
I suddenly realized, I wonder whether we have recorded the session. I mean, you haven't.
You can't see
from your side.
I can't see any signs that it's being recorded.
Yeah, that's right.
Okay. But it's okay. Probably next time. And thank you all. And also, I noticed a lot of other colleagues from different areas who are also watching this. I hope it was enlightening and you too enjoyed the session. Thank you very much. I look forward to further such interactions with you and would await the information that you share about the patients we discussed today. Thank you very much. Thank you.
Thanks a lot. I can see one of my friends here, Mr. Rono Joy. So while others are leaving, I'll probably catch up with him because it's been 10 years since I saw him. And interestingly, he is here. So, yeah. So, Mr. Rono Joy, are you there? Can you?
So all the others can leave the session and we can leave them to catch up with each other. Thank you very much again.
Thanks a lot.
Thanks, Dr. Rakesh.